Welcome to this explainer. Today, we're taking an exhaustive postgraduate level deep dive into Chapter 464, Alcohol and Alcohol Use Disorders. We are going strictly micro to macro here. We'll start right at the cellular level, trace the physiological impacts all the way through the body, and ultimately land on the clinical management of a condition that, frankly, affects roughly 20% of our patients. It's a hugely complex, multisystemic challenge, but once we break it down step by step, the underlying biology and the evidence-based treatments become incredibly clear.
Okay, let's look at our roadmap for today. We'll be covering Section 1, the metabolism of alcohol, Section 2, blood alcohol levels and tolerance, Section 3, laboratory and serologic biomarkers, Section 4, diagnostic frameworks, and finally, Section 5, pharmacotherapeutic management. We've got a lot of fascinating ground to cover, so let's jump right in. Section 1, metabolism of alcohol, from molecule to toxin. We begin our journey at the molecular level, looking at exactly how the human body processes beverage ethanol, a process that happens primarily within the liver. Let's see how this metabolic process builds across 3 vital steps. When ethanol is absorbed and hits the liver, it is first oxidized in the cell cytosol into a highly toxic compound called acetaldehyde. This initial heavy lifting is handled primarily by the enzyme alcohol dehydrogenase, or ADH. Now, because acetaldehyde is so incredibly toxic, your body has to clear it out rapidly. So in step 2, the enzyme aldehyde dehydrogenase, or ALDH, which operates in both the cytosol and mitochondria, converts that toxic acetaldehyde into acetate. Finally, in step 3, that acetate enters the citric acid cycle as acetyl-CoA, where it is ultimately processed into carbon dioxide and water. Now, what's really fascinating here is the MEOS pathway. While ADH handles the bulk of ethanol metabolism under normal conditions, the microsomal ethanol oxidizing system, located in the smooth endoplasmic reticulum, acts as this crucial backup system. It kicks in specifically during heavy drinking to handle the massive excess ethanol load. In fact, at high blood alcohol concentrations, this secondary pathway is responsible for 10% or more of ethanol oxidation. It perfectly demonstrates the liver's incredible adaptive capacity to manage a systemic toxin. Section 2. Blood alcohol levels and tolerance. As cellular metabolism reaches its absolute limits, we have to zoom out. Let's observe how rising systemic blood alcohol levels directly manifest as clinical and cognitive deficits in the patient. This brilliantly illustrates the dose-dependent toxicity of ethanol on the central nervous system. At a relatively low blood alcohol concentration of 0.2 grams per deciliter, the clinical presentation is mild, decreased inhibitions, and a slight feeling of intoxication. But as we move up to 0.08, which you'll recognize is the threshold for legal intoxication in most U.S. states, we see a marked decrease in complex cognitive functions and motor performance. Push that level up to 0.20, and the toxicity becomes profound. We're talking obvious slurred speech, severe motor incoordination, poor judgment, and high irritability. To actually survive these repeatedly toxic levels, the human body is forced to adapt. It develops 3 distinct forms of tolerance. First, there's metabolic tolerance, where the hepatic metabolism rate physically ramps up, sometimes by 30%, after just a few weeks of daily drinking. Then, there is learned or behavioral tolerance, where the individual essentially learns to mask their impairment and function under the influence. But the most profound adaptation is cellular or pharmacodynamic tolerance. Down at the neurochemical level, excitatory NMDA glutamate receptors and inhibitory GABA receptors physically alter their density and sensitivity. The brain is quite literally rewiring its neurotransmitter baseline just to maintain physiologic function in a constantly alcohol-soaked environment. Section 3. Laboratory and serologic biomarkers of heavy drinking. The absolutely crucial point here is that when these physiological adaptations occur over time, they leave a distinct biochemical footprint. And as clinicians, we can measure that footprint to detect chronic heavy drinking. When evaluating a patient, these specific elevated thresholds act as massive red flags. We're looking for gamma-glutamyl transferase, or GGT, pushing past 35 units per liter. We want to check if carbohydrate-deficient transferrin, or CDT, is exceeding 20 units per liter. Add to that a high normal mean corpuscular volume, or MCV, of 91 or greater, and serum uric acid sitting above 7 milligrams per deciliter. When you see these markers elevated in a patient's labs, they strongly reflect a chronic consumption pattern of about 6 to 8 standard drinks every single day. Why this matters so much in a clinical setting really comes down to diagnostic confidence.
By combining just two of those tests, the GGT and CDT blood tests, you achieve a sensitivity and specificity of over 60% for detecting heavy alcohol consumption. These are incredibly powerful, objective serologic tools that cut right through any denial or underreporting you might encounter during a patient interview. Section 4. Diagnostic frameworks for alcohol use disorder. Having established the objective biological markers, we now zoom out even further to the clinical presentation. We need to see how this cellular dysfunction and tolerance translates into a complex, diagnosable behavioral disorder. The DSM-5 framework is our clinical gold standard here. It diagnoses alcohol use disorder not just by the raw quantity of alcohol consumed, but by the negative impact it's actively having on the patient's life. A diagnosis requires a clustering of at least 2 out of 11 functional and physiological impairments over a single 12-month period. These criteria look at loss of control, like intense craving, or drinking larger amounts than intended, but they also loop in those physiological markers we discussed earlier, the presence of tolerance, experiencing withdrawal symptoms, and most tragically, continued use despite undeniable physical, psychological, or interpersonal harm. But before you run a full DSM-5 diagnostic workup, you need a quick way to screen patients in a busy primary care setting. That's exactly where the AUD questionnaire comes in. A score of 8 or higher on this 10-item test is your immediate clinical threshold. If a patient scores an 8, it identifies potentially harmful alcohol use and serves as your trigger to initiate a brief intervention, to actually start having that vital conversation about their drinking habits. Section 5. Pharmacotherapeutic management options. Once a diagnosis is made and the patient is moving into rehabilitation, our focus completely shifts. We have to provide evidence-based, targeted solutions to help mitigate the intense neurochemical cravings and protracted withdrawal symptoms that make recovery so difficult. Here, we can compare our frontline recovery medications, which beautifully target completely different neurochemical pathways. On one hand, we have naltrexone. This is an opioid antagonist. It blocks the dopamine reward loop in the ventral tegmental area of the brain. Simply put, it decreases the feeling of pleasure if the patient drinks, severely weakening that behavioral reinforcement. On the other hand, we have acamprosate. Remember that cellular tolerance we discussed earlier with the hyperactive NMDA glutamate system? Well, acamprosate acts as an NMDA inhibitor. It stabilizes that hyperactive excitatory system to ease the persistent, lingering symptoms of protracted withdrawal.
We also have a third, much older option, dialsulfiram, and this one directly relies on that metabolic pathway we mapped out earlier. Dialsulfiram works by actively blocking the ALDH enzyme. So if a patient takes this medication and then consumes alcohol, their body literally cannot process the ethanol past the acetaldehyde stage. The result is a rapid buildup of highly toxic acetaldehyde in the blood, causing an acutely aversive reaction. We're talking severe vomiting, flushing, and autonomic instability. It acts as an incredibly powerful psychological deterrent, though it must be used very carefully due to the potential medical risks of that reaction.
As we conclude this explainer, we really have to look to the horizon of addiction medicine. We've seen how alcohol rewires receptor densities and alters metabolism, but modern research is going even deeper into epigenetic modifications, like DNA methylation and histone acetylation, which physically alter gene expression in the brain's reward circuitry. It leaves us with a truly provocative question. As we map these lasting, drug-induced epigenetic changes, how soon might we be able to completely reverse the cellular roots of addiction, moving far beyond symptom management to genuine neurocellular repair? It's a fascinating frontier for medicine. Thank you so much for joining me on this deep dive.